Muted.
I'm with Children's Advocacy Services and the Missouri Academy of Child Trauma Studies in St. Louis. And we are so excited. I mentioned to someone, I think I actually got the phone call from Emily about this project in June or July-ish of this year, which was really exciting. So it's always nice to have projects get launched. And for those of you on the webinar, we are thinking about you and so glad that you're also taking your time to be here today to learn about this year-long project. So first we're going to start off with some introductions. So again, I'm Amy. I want to introduce my colleague, Dr. Matt Creaserman. So he is one of our nationally certified trainers in CBT. So he will be taking a really active role on that. We also have a larger training team that isn't here today, but that if you choose to apply for the training and then get started, you'll get to meet all those people as well. So now I want to turn it over to Emily Van Cleef with Missouri Kids First, who's going to give us a little bit more background information about the project.
Hello, I'm Emily Van Cleef. I'm the Deputy Director at Missouri Kids First. And for those of you that don't know, Missouri Kids First is a statewide child advocacy organization that works to address and prevent child abuse. I am really excited to get to talk to you a little bit today. This has been something that's been in the works for quite some time. We are here today because of the work of the Task Force on the Prevention of Sexual Abuse of Children, which was a group of folks that came together to decide that we were going to work to address the epidemic of child sexual abuse in our country, and that we were going to do a better job of meeting the needs of these children. So we started thinking about and working on what are the key things that could help us to stop sexual abuse and to more appropriately respond to it. And one of the things that we kept coming back to over and over again is the importance of mental health services and evidence-based mental health services. And so our task force kind of got together and said, you know what, we need to have ongoing funding and infrastructure for supporting evidence-based mental health services in this state. One of the things that we know is that we pretty much know what it takes to help heal kids. And certainly no one model can do anything for all kids, but we have really good science now about how to help children recover from trauma. But the models to do this are expensive and time-consuming, and they're not typically supported very well by our traditional payment mechanisms. And so when you want to do the work the right way, it's often cost prohibitive. So we worked at the General Assembly to establish an appropriation, a small, relatively small, doesn't feel small to me, but for our state budget, very small, $500,000 appropriation, ongoing funding to support evidence-based mental health services in the state of Missouri. And so this funding we secured in the last General Assembly, and that money goes to the Department of Mental Health and then to the Coalition of Community Behavioral Health Care to fund efforts to increase access to evidence-based mental health services. And this is the very first thing that we are doing. The group that is advising about how we spend this money and what we do to do this is called the Missouri Children's Trauma Network. And we are a group of advocates and experts that are working to increase access to evidence-based mental health services. We want every child in this state that has experienced trauma to be able to have access to the best, highest quality mental health services. And so for this first year, we're really going to work on getting lots of training out there. We want more evidence-based models, so we're going to try to make it as easy as possible for people who want to do this work to be able to do it by offering spots and learning collaboratives and certain evidence-based models that we believe have the best science behind them supporting them. And so this is our first one, trauma-focused cognitive behavioral therapy. And for child advocacy centers in Missouri, this is one of the models that we use the most and believe is most appropriate for our population. We are also going to be offering learning collaboratives and parent-child interaction therapy, EMDR, motivational interviewing. So I'm hoping that you will begin to hear more and more about the Missouri Children's Trauma Network and our efforts to increase access to evidence-based mental health services. We are going to be starting with training. We hope to continue to provide lots of these collaboratives because let's be honest, there's a lot of turnover, there's a lot of need. We don't need to just have one learning collaborative. We need to have lots of learning collaboratives. So we hope to continue to offer these. We also want to be very responsive to the needs in the field. You know, I want to hear from you all about what your needs are. I want to know what models you want to explore. I want to know what systems and barriers are getting in the way of you providing effective services. So I do encourage you all to reach out to Missouri Kids First, reach out to the Missouri Coalition of Community Behavioral Health Care, and let us know what your need is. Some of the trainings that we started off at the beginning of the year we're definitely doing. We've added a few. We added EMDR because people kept saying we want more EMDR training. And so we want to be responsive to the need. We know there are other models that we should explore. So please, your feedback, the feedback from people who are directly working with kids on the ground is critical to this project's success. And so let us know if you are seeing a gap and there's some way that we could help you in meeting your needs. This group, we really do also hope to explore systems and barriers, payment mechanisms for this type of work, looking at screening, assessment. You know, our goal is to dramatically improve access to evidence-based mental health services for traumatized children in the state. And that is, there's probably a lot of different ways that we need to go about doing that. And so we're committed to this for the long haul, and excited to be here today at our first launch of our first learning collaborative. And really excited for everyone who is joining us on the call and everybody who's here in this room. I think that it's really important to note how much support there is for this work. When I worked on this appropriation at the Capitol, when I went around talking to people about the need to serve trauma victims and do a better job in increasing access to evidence-based mental health services, there was not a person that didn't agree that this was an extremely valuable use of our state funding. The General Assembly loves this work. They love the work that we are doing here. They love that we are pushing ourselves to get better on this. The Department of Mental Health is committed to doing a better job with trauma. They are committed to meeting children's needs. We have a coalition of community behavioral health care, the CMHCs of the state, child advocacy centers of the state, community-based providers. So many people want to do this work and want to do it well and are a part of this team. And so I always believe when you have a really good idea and have a team of people that are working to support it, it's amazing what you can accomplish. So really, this is just the beginning. I hope that when we're 5 years down the line from this, we will look back on this moment and think that we have made incredible progress, that there are folks who are trained in CBT all over the state, that this is a model in addition to lots of other models that that are proliferating all around the state, and that our kids are getting better access to services. And so I'm really excited to be here, really excited that you are a part of this. And if there are any questions about the context of this, if there are any questions you have for me, I would be happy to answer them. I always think it's very clear, and then I realize that not everybody lives in my world, and I probably omitted 7 different things, so it would be helpful for understanding the context of this. But I do want everyone to understand why we're here today, where we came from, and where we want to go. Questions?
Do we have any information that provides us with your contacts?
No. I'm Emily. So if you look, it's probably the easiest way to get that would be to go to Missouri Kids First website. So Missouri Kids First, Google Missouri Kids First, and my contact is on there.
And I'm Katie Horseman with the Coalition. Hopefully some of you have seen emails from me. If you haven't, you'll probably see a lot with the Learning Collaborative. But we also have a website for the Missouri Children's Trauma Network. So the Learning Collaboratives that Emily has mentioned, they're up there, and information is on there, and then contact information about that. And we hope to have more resources online there too. And I will be going through that at the end of this, so you guys can see that, get a feel for that, and you can go back to your agencies and look at it and the different learning collaboratives and things that we have going on, because a lot of the registration is currently out for, I know the motivational interviewing, the Trauma-Informed Learning Collaborative is out, and we're working on PCIT training and the EMDR. So lots of great things. But you can get to us via that website and also Kids First. Sorry, one more thing. For the people on the webinar, just wanted to let you know we do have people in this room that we're talking to, so it's a bit of dynamics here with the webinar and then the in-person. So if you have questions, please feel free to raise your hand. I'll try to check it as we go if you have questions throughout the presentation, and then also please feel free to enter those in the question box. In order to unmute your line, you will have to have that audio PIN number in. You should be able to find that on the drop down of the audio box. But otherwise, we'll get started, and then we'll check in and out on the webinar portion to see for questions.
Okay. As Amy mentioned earlier, my name is Matt Cleathermus, and I am one of the MOAC faculty, also the training director at Children's Advocacy Services of Greater St. Louis, and just wanted to spend a little bit of time telling you about the Missouri Academy of Child Trauma Studies, which is essentially Children's Advocacy Services of Greater St. Louis is a fully certified children's advocacy center in Missouri, and we are technically the training arm of that agency. So we are actually also part of the psychology department of the University of Missouri St. Louis. And over the last 8 years, we've really kind of moved from being, while still very active in providing these services to the St. Louis community, we've also been doing a lot of training in evidence-based practices across Missouri and across the Midwest, truthfully. We've trained about 750 people in TFCBT at this point, and every year in various topics related to trauma, we pretty annually train over about 1,000 people. So we are also affiliated with the National Child Traumatic Stress Network and funded through the Substance Abuse Mental Health Services Administration. So this is really something that we are very, very passionate about. We really have wholeheartedly kind of taken on the issue of training with evidence-based practices, because even within a community like St. Louis, there's not a lot of access to these services. And so we are really trying to hopefully get Missouri at the forefront in terms of having availability with these kinds of services for kids. So the next step that I want to do is just give a little bit of a rationale for why we're talking about trauma-focused CBT, and a little bit about what TFCBT is as well. So one of the just basic reasons that we need it, and as I think everybody in this room well knows, trauma has a pretty significant impact on kids. It definitely leaves a fingerprint that shows up across all kinds of settings, home, school, social, you name it. We see this kind of fingerprint, and it really doesn't go away unless we do something to address it. And really that's where evidence-based practices, including TFCBT, come into play. Because what we know is we don't undo trauma just by putting kids in a situation where trauma is not occurring. These consequences tend to stick in the sense that these thoughts and memories that the child has about their trauma continue to leave them in a state of just ongoing fear, anxiety, distrust, a sense of not being safe in their own skin. So as Emily mentioned, there are a lot of models, truthfully, for treating trauma exposure in adults and kids. I want to talk a little bit about what TFCBT is, in the sense that it is a trauma-sensitive model, but also a cognitive behavioral model. In many respects, you can say that the trauma part is probably even more important than the CBT part. We definitely talk about cognitive therapy constructs, and interventions are definitely, there's cognitive nature to it. But really the essence of TFCBT is the focus on giving kids and families the skills they need to talk about trauma and work through what that trauma means to them and how it impacts their life. It is considered a well-established evidence-based practice for child trauma. We're going to touch on the research related to TFCBT a little bit later, but it is definitely very well established. I think something that's a little bit of a distinction for TFCBT, as opposed to a lot of treatment approaches for kids, is it is a therapist-directed model. This is not a non-directive therapy. It's not like non-directive play therapy. The therapist is the person who is setting the content and pace of sessions with kids. So the main reason we do that is one of the hallmarks of trauma exposure is avoidance. So if a therapist isn't establishing that sort of pace and content, kids will continue to avoid, and adults will too, for that matter. And so therapists structure sessions really in two ways. One is that we really do recognize that kids do not have the same emotional or cognitive capacities that adults do. So we need to give them the skills they need to process trauma before we ask them to do it. So the initial parts of TFCBT are very skill-focused, but we are always coming back to the idea of trauma and that we need to address and process and face the memories of trauma that kids have experienced. So this is a very busy slide. I'm not going to read everything on here. I absolutely promise that. But in essence, does TFCBT work? And pretty resoundingly, the answer is yes. There have been quite a few research studies that have been done on this. I believe the last I heard there were like 15 very well-controlled, randomized research studies related to the implementation of TFCBT, and all of them show that it is significantly more effective than just general practice in terms of reducing symptoms related to post-traumatic stress. It's been identified as a model program and best practice for use of abused and traumatized kids. And of note, I think something that's important is when we think about trauma-focused CBT, I think a lot of times people view it in the context of post-traumatic stress symptoms, and it is absolutely efficacious in addressing those, but we also see significant improvement related to depression, anxiety, externalizing behaviors, sexualized behaviors frequently associated with sexual abuse, and just general feelings of shame and mistrust. So this goes beyond just helping with avoidance or hyperarousal or re-experiencing symptoms. And what's really phenomenal about TFCBT, and it really involves how much we include the caregiver in treatment, we also have found across quite a few research studies that symptoms that the caregiver may present with also improve over the course of intervention. So a caregiver's level of depression or distress also tends to decrease by participating in TFCBT. So, any questions about all that so far? I know I'm rambling right through this. Okay. Well, I am...
Sorry, I was looking at the webinar to make sure there wasn't any questions.
Okay, so I am really not going to read this slide. But basically, like I mentioned earlier, it has been identified by multiple sites as being a well-supported, basically treatment of choice for trauma-exposed kids. Now, this next slide, I think, is a helpful one because it talks about what is TFCBT, who is it appropriate for. And the age range that TFCBT has been studied with goes from 3 to 18. So obviously, any treatment intervention for a 3-year-old is going to look different than it will for an 18-year-old. But the basic components of TFCBT remain the same. It's really more how you implement them that becomes a little different. It can be used to address single or multiple traumas. So I think there are some misconceptions that TFCBT is only appropriate for like a one-time trauma, which is actually not true. And research pretty clearly indicates that even for kids exposed to chronic, multiple types of traumas, you will see the same sorts of benefits from using the model. It's also helpful for use with kids who have been exposed to a traumatic loss, like witnessing a homicide, and are dealing with the subsequent grief and trauma interactions after that event. There are actually additional components to address grief related to traumatic loss that are sort of in addition to typical TFCBT. And really, TFCBT has been implemented in just about any sort of setting that you find kids. It's been used in residential settings, foster homes, schools, kinship placements, group homes, juvenile justice centers. I mean, it's been used effectively really anywhere you can find a kid. So I think one of the things that is a hallmark of TFCBT is it really is intended to be a relatively short-term treatment. So in general, we're talking roughly 12 to 18 sessions is sort of considered a standard implementation of TFCBT, with really the more kind of chronically exposed kids, very complex cases, lots of just environmental crises going on. That may be somewhat to like 25, 30 sessions, depending on the client. But it is still considered to be relatively short-term. And looking at those research studies, what we see is over 80% of kids who get TFCBT have shown significant symptom reduction over that 12 to 16 weeks. So roughly 8 in 10 kids get better significantly in a few months when doing TFCBT. Talk a little bit about the next one. Oh, I think something also, a concept that I think is useful is, as I think Emily mentioned, there are lots of ways lots of interventions out there. There are a lot of treatment models, and there are a lot of just mental health needs that go beyond what TF-CBT is going to address. So I think the other way that TF-CBT can be very useful is in the context of a larger treatment plan. So it can be used sort of like in conjunction with something like dialectical behavior therapy with parent-child interaction, as mentioned. So it's something that can fairly easily be kind of implemented as part of a larger plan, specifically to address those clear trauma-related symptoms. Okay. So I think, how many of you guys have heard of TF-CBT and heard of it sort of described as a manualized treatment? Has that ever heard of it? Okay. Well, that's one of the things. I hate the word manualized, and I'm going to explain why, because TF-CBT really isn't a manualized treatment. It has components, but it doesn't really dictate how those components are implemented. You know, what I do, like I mentioned earlier, how I implement a component of TF-CBT with an 8-year-old may look nothing like it is done with a 12-year-old or a 5-year-old. So TF-CBT really does work best when it's being delivered by a creative, resourceful therapist who has a really good relationship with their client. So just good basic therapeutic skills are necessary. One of the TF-CBT developers likes to say that if a bad therapist does TF-CBT, you just get bad TF-CBT. You need to still be a good therapist for TF-CBT to be effective. And so the reason I say that is because I think people get lost in the idea that this is some sort of manualized cookbook treatment, in which it is very much not. Every iteration of TF-CBT I do looks a little different from the one I did before. And that's really to meet the individual needs and the developmental needs of every child and family I work with. I think another interesting thing about TF-CBT is it has been evaluated with a lot of different ethnicities, cultures. It's been pretty extensively tested with both Caucasian and African American children, adaptations for Latino families, for hearing impaired and deaf populations, even with Native American populations. And something that's been going on quite a bit recently is it's being implemented pretty extensively in some of the countries in Africa where there's be a lot of exposure to like genocide, cultural warfare. It's being used successfully in those settings as well. So it tends to, the efficacy tends to hold pretty well across different cultural groups. So I've talked a lot about why TF-CBT is a great thing to do. Now I'm going to talk a little bit about exactly of TF-CBT in the sense that we're trying to provide, oh, I guess I can't, yeah. Actually, Amy just pointed out that's kind of the next slide, if I can get it. Okay, so the psychoeducation, parenting, relaxation, affect education, and cognitive coping is designed to provide the foundation that we need to do the later trauma processing. So to do that, we're building a lot of skills and providing a lot of education about what trauma is, how trauma impacts functioning. We learn about relaxation to address some of the physiological impacts of trauma. We learn about how to express, identify, regulate emotions due to the emotional impact of trauma on kids and families. And we do a lot of work with cognitions and cognitive work to address the different types of cognitive distortions, thinking errors that typically come along with trauma exposure as well. While we're doing this, however, we never stop talking about trauma, and that's that concept of incorporating gradual exposure. Throughout relaxation, affect, cognitive coping, we're talking about it always in the context of trauma and how trauma impacts emotions. the types of emotions that kids may typically experience when they're exposed to domestic violence or exposed to physical abuse. So we're always tying it back to trauma to keep that focus going and gradually building up their capacity to tolerate direct discussion of their own trauma, which is what happens in the second half of TFCBT. So trauma narrative and processing, we're taking all of that knowledge and skills that we built up in the first half of treatment, and we're having the child in some way, shape, or form share their experience of the trauma they were exposed to. So just the typical, most common way of doing this is through some sort of story format. This can also be done through art, through puppet shows, through sand tray play. There's really no limitation to how you do trauma processing within TFCBT. It's just more a matter of we are directly working with their memories of their experience. So we do have a much more heavy focus on that gradual exposure, but we're also starting to think about how they can use those skills for their future after treatment. How are they going to use the relaxation skills they've learned, the affect skills they've learned, the cognitive skills to help them deal with the stressors that they're going to face throughout the rest of their life? How are they going to take lessons learned from their trauma exposure? Maybe things like, I've learned that it's important for me to be assertive with, and really stand up for myself. I'm going to keep that meaning and I'm going to use that throughout the rest of my life. That's something I've learned here. So I've learned that I can really rely on my mom to be someone who I can come to with problems like this. I'm going to keep that relationship there so I can make sure I have that person to talk to after treatment. So really, when I think about TFCBT, the first part we're really kind of focusing on trying to help them in their present. How do they deal with the stressors that are going on right now? Then we deal with talking about their past trauma, and then we tend to focus on the future. So it's sort of like we stabilize the present, we process the past, we prepare for the future. This is just a visual of kind of what I just said, so I don't think I need to say a whole lot about it. In fact, I'm not going to say anything about it. How about that? Then the last major thing I wanted to talk about what TFCBT is, and I alluded to this earlier, is that the caregiver is a critical component of TFCBT. We generally try to structure TFCBT so that sessions are divided between the caregiver and the child. So when I'm in psychoeducation and the child's learning about what trauma is, the impact of trauma, what post-traumatic stress is, all of that, I'm also working separately with the caregiver so they understand those things as well.
Muted.
We tend to keep them separate initially and don't just do this all sort of together the whole time, is because we want to give each person, the child and the caregiver, the room to have their own reactions initially, the room to ask questions that they may not feel comfortable asking in front of the other person. Also, just to be very honest, we want to make sure that the caregiver isn't seeing something from the child's exposure that's overly distressing for them, and vice versa. We don't want the caregiver, if we've got one who doesn't necessarily believe the child's disclosure, to be actively sharing that with them in front of the child. So we're really trying to keep them separate initially so we can make sure that this is going to be productive when we ultimately bring them together for the conjoint sessions. So we get the skills, the knowledge in place, we make sure they're handling it okay, and then we bring them together to try to facilitate them having conversations and engaging in this kind of trauma work together. Because ultimately, TFCBT, like I said, is a pretty short-term model. We see them for a few months, maybe 6 months tops, roughly, and this kid's going to have needs that extend beyond that 6 months. And that caregiver is who's going to be able to meet those needs. So we want them to be trauma-informed and be in a position where they're able to provide that support. Okay. So I'm done talking about TFCBT, so I'm happy to answer any questions either in the room or online that people have about the model before we move on to talking more about the learning collaborative process. Oh, I just did a really good job explaining it. That's what it is.
I know that on the webinar they have had questions regarding the PowerPoint, if it can be shared. And I believe Amy had said that yes, in PDF form, and we'll get it online and sent out to them.
Yes.
That's the only major one. I might have some hands raised. I have a couple hands raised if we can.
Sure. Okay.
Rita Wharton, I have your line unmuted. Did you have a question? Kim Barnes, I have your line unmuted. Did you have a question?
No, I'm having some technical difficulty.
Oh, okay.
Thank you.
Seems to be working right now?
Yes,
Okay, good.
thank you.
Thank you. We'll try one more. Sharita Allen, did you have a question? Oh, it won't let me unmute. Okay, it won't let me unmute her. Okay. If anybody has any additional questions, if you want to enter it in the question box, I would be happy to read it off or unmute your line if I can. But I don't see anything currently, so does anybody here have questions?
Well, if anything comes up, either for the people online or for all of you, you know how to get a hold of us. So I'm happy to take any questions about the model that come up.
Right.
Maybe when you go back to wherever you come from and talk about it. You know, if anything comes up, just let us know.
Right, and with that in mind, we will move on to talk a little bit more about how TF-CBT fits within this larger learning collaborative. And the reason we wanted to start off with TF-CBT is that we want to make sure that in our efforts that it's really a model that's going to work for various providers for their practices within their community. So we want you really to be thinking through like how well do I feel like this model will fit rather than having you sign up for a year-long training and then it's probably unlikely within our likelihood that, or within our lives, that we will end and keep all kids from ever experiencing stress or trauma. But within the Missouri Academy of Child Trauma Studies, we really feel like we can really improve the outcomes for those kids, and that we really want to see all children who've experienced trauma be assessed and screened by competent professionals within the community, and then referred on to evidence-based practices like TF-CBT. Because we really want to build these collaborative networks that are responding to all the needs of the child and the family within that community. So within that, we are using a trauma-informed system of care perspective that comes from the National Child Traumatic Stress Network, where we want everyone sort of who circles around the child and family as part of that response to really understand how is it that trauma is impacting this family. How can we take that trauma-informed lens and incorporate that into our treatment planning so that we don't have 5 different providers all making different treatment plans for the same family, where all members of the family have PTSD and are having trouble concentrating and attending to the treatment plans anyway. Let's make sure we're being realistic here. We also want to make sure that to help everyone understand this is what their specific role is within that responsive system. So what is the mandate of my role as a therapist versus my colleague's role as a case manager versus a different person I work with, their role as a deputy juvenile officer? What is that professional responsibility, and then how can we be aware of when those professional mandates might be at odds with each other versus how can we help build those networks of understanding? Because ultimately that's what's going to be needed to have the best treatment options and the best outcomes for these kids and families. So we've included here this sort of definition of the child of the Trauma-Informed Child and Family Service System. Again, this comes from the National Child Traumatic Stress Network. But what we really want to point out here is that these children aren't the responsibility of any one person. Our work is exhausting, and so often the buck kind of gets passed of like, okay, phew, my client's an inpatient, so they're not my responsibility. Now I can like actually eat lunch this day rather than seeing this person. But that doesn't truly put the child first. And so we need to sort of move beyond that kind of siloed approach to saying this really is the responsibility of the whole community to care for these kids and families. It's not just the school counselor. It's not just the outpatient person. It's not just children's division. And it really is going to take that collaboration to be able to make these meaningful changes that are both sustainable and that are going to help promote not only recovery, but also some post-traumatic growth. We don't want these kids and families just to bounce back. We want them to bounce back to where they are, but also bounce forward to be able to maximize their developmental potential. So what I have up here on the screen right now, Matt is laughing at me, is a very complicated visual explanation of what we mean by this learning collaborative process. So I'm not sure how many people have participated in the learning collaboratives before, but there's a little bit of lingo that I'm going to talk you through. This information, if you're more of a verbal person, is also going to be on page 9 of your application packet. So what this visual does is it talks through, within this collaborative, well, wait, first of all, question, how many people have gone to a training, they've been so excited, they go back into the office the next day, and they have this warm, fuzzy feeling? That was such a nice training. But then you start to think through, like, now what was it that I was so excited to do, or how do I implement this? And your brain just like goes poof, right? So what was developed actually within a healthcare context and has been proven through research studies to be a more effective way of having long-term changes in clinical practice, be it in healthcare or mental health, behavioral health systems, is a learning collaborative approach where you have these, okay, so where you have multiple different training tracks and there's multiple different learning sessions. So right now on the left side of the screen, you'll see the pre-work phase. That would be the phase of this learning collaborative that we are sort of in right now, where we are launching this project. We're promoting it. We want to get buy-in from communities around the state of Missouri and people saying, like, yes, this is what I think is needed in our community. So from there, individuals will be talking through what the different roles are, because we have clinicians, those are the green, clinical supervisors, we have our senior leaders, our organizational leaders, and then the blue is the brokers of service, and those are what we often think of as a multidisciplinary team. So I'm going to talk in more depth about kind of what all those different roles are and what would be involved in the training track. And then you'll see we have what we call learning sessions. Those are going to be our face-to-face trainings. For this training, there's 3 of those face-to-face trainings in the next 6 to 8 months, March, June, and September, the dates of which are in your packet. And then in between each learning session, we're going to say, take all this information, go out, try it out, consult with us over phone calls, see like what's working, what's not working, what are roadblocks that you've come across, and then have other people in the training overcome similar roadblocks. So it's not that it's like you're learning from our staff and faculty, you're going to be also learning from the other people within your group. Because I know there's people on the webinar and maybe some people in this room that maybe they've already gone through one of our trainings as a clinician and now they're going to go through as a supervisor, right? So those people have a lot of experience that they can offer to sort of help other people as they move through. So you'll have tasks then in between each of the learning sessions so that people feel fully supported. So you're not just this like lone wolf out there being like, okay, I did the online training, I read the book, now how do I implement this model when, you know, something kind of goofy comes up. So this is here mostly just for your informational purposes. If you're accepted into the training, you get like a nice pretty handout version of this. So just to keep you oriented, we're currently in the pre-work phase of the Learning Collaborative right now. So let's talk a little bit more about who these participants are. So we want to make sure that we are setting all of these communities up for success. And so in order to do that, we need to make sure that our senior leaders, our organizational decision makers, are aware of what TFCBT is, about how can they promote it within their organization, how importantly can they make sure that it's funded, right? Because we don't want clinicians to spend time going through this training if they don't have any funding to see people using this treatment model. And so it's really important. These are the people that can help make decisions about how often is a clinician able to see a specific client or things like that can help with these sort of structural issues about workload, policies, and practices. And it's really helpful for sort of sustaining the fidelity and making sure that the model is being implemented as anticipated. In addition to that, we have our brokers of service. So this word throws people all the time. And the reason we use the term brokers of service is that was the term used through the National Child Traumatic Stress Network. It's just what we mean by this is brokers of service are going to be anyone in the child and family's life who sees them within a professional context, identifies them, and helps make treatment decisions for them. So it might be a school counselor who sees a client and says, you know what, I'm really worried this kid might need some trauma therapy, and refer them on to the CAC. It might be a deputy juvenile officer where they feel as though it's the child's trauma symptoms that are contributing to the truancy that says, you know, I think we need something more than general therapy. They need something more specific. So for those of you from the CAC background, we're thinking like members of the multidisciplinary team here. This training track is really open to anyone. We've had law enforcement people participate in this before. We've had prosecutors, physicians. So it's really like, who are the people in the community that are willing to say, like, yes, this is part of my responsibility to help with this, and are willing to sort of jump on board. All right. So I'm going to pause here. Questions about who we mean with these brokers of service? Because sometimes clinicians get missed about this when I say this, but these brokers of service, these individuals are absolutely critical to be able to implement TF-CBT successfully. These are the people that when you're having a family that's not coming into session regularly, they can help you solve that problem. These are people that can help, like if a child has to change placement, ensure that that's done in a trauma-informed manner so that you can keep moving forward on your goals as a therapist. And in addition, these are basically the brokers of service. They're basically the people that hire the clinicians, right? They're the people that say, yes, I will refer cases to you. And so if you don't have, if I'm practicing TF-CBT but no one knows about it, I'm never going to learn the model. I'm never going to be able to use it effectively to help kids if I don't have colleagues that are referring these cases to me. So questions about this piece? Yes?
I was looking at the packet. On the team application,
Yeah.
there are spots for brokers.
Yes, sir.
So when we do this, do we have to go and list these people to put them on the team?
So I'm going to potentially, yes. So nobody needs to panic about putting together teams. We're going to help you do that, and then we have a whole bunch of slides about how to do that to try to make it more concrete.
We have a few questions on the webinar. Can we address some of those? Okay, so Christina Hannon had a question. It said, would it be appropriate to include staff from our local Children's Advocacy Center? Do they have to be individuals outside of the agency, or could this be our CSS?
Definitely does not have to be outside of an agency. It's going to look a little bit different for each organization. So we've worked with organizations before where they have psychiatric care, case management, behavioral health services all in the same place. So they sort of are a team unto themselves. Or we work with places where like the CAC is sort of the hub and they invite their community partners. Or we work with groups where it's individuals in private practice that just kind of say like, yes, this is important, and kind of take the leadership within their community for pulling together people and kind of recruiting people.
Okay. And then Elizabeth Crawford asked again about the PowerPoint, which will be shared after the webinar, and along with that we'll share the application form, or has it already been shared with them prior to?
So everybody here and everybody in person on the webinar, when you receive your confirmation email, should have received copies of the application. They'll also be posted on the website, and then we'll do everything we can to make sure everybody has copies of those. Okay.
And then there was Melanie asked the question, have you faced any challenges regarding a lack of involvement with caregivers? Can this be individualized for children that may not have caregivers that are 100% involved?
Yeah, it's a great CBT question. I'm going to let Matt answer that.
Yeah, that is a really good question. And basically what is the simple answer to that is it is possible to do TFCBT without a caregiver. We generally try to get the caregiver if at all possible, just because what we have seen is that there are certain symptoms that are trauma-related symptoms, like the things like sexualized behaviors or other behavioral difficulties that do not tend to improve without a caregiver involved in treatment, which that just makes good clinical sense that behavior stuff, you tend to need a caregiver to address that. The other thing that is noteworthy from research is that treatment gains don't tend to be kept as long when you do not have a caregiver involved in treatment. So they show the same level of improvement, but they tend to drop off once treatment has ended. And I think that really speaks to the role of the caregiver as sort of like the surrogate therapist after the end of treatment and how important that can be. But I can say within just the framework of TFCBT, I have done it many times with absolutely no caregiver involvement and have had it been successful. So it is possible to do that.
All right. Right. One more question that we had is from Allison. It says, are there any books or manuals about TFCBT that you would recommend?
Definitely. So that I'm also going to table for talking about the more specific expectations for the training tracks, because reading one of the TFCBT books is part of the work. So we'll come back to that. All right, so clinicians. So our clinicians are going to be the people implementing TFCBT, and our training, which I don't think we've mentioned yet, but all of the training requirements that are part of this training are in accordance with the guidelines by the developers of TFCBT and are consistent with what's required at the national level. So some of the requirements that you're going to hear about aren't from us, but they're from the developers of the model. So those requirements are that to be in the clinician track, one needs to be a master's level or higher mental health provider. It is okay if someone is in their graduate training to be a counselor or social worker or in psychology to participate as a clinician. All of the people who are in the clinician track and complete all of the training requirements will then be eligible to be rostered through the Missouri Academy of Child Trauma Studies, and then also eligible, if you wish, to apply to be a certified provider of TFCBT at the national level. And so I think for right now, I think it's just important that you know that you can level on the national level. And at the end, if someone has questions specifically more about that, we can talk through that in more depth.
Is there TFCBT for individuals over 18?
And I've gotten asked that a lot, and there's a couple ways to answer that question. Is what the developers of TFCBT would say is if it's someone who is developmentally over the age of 18, if they're 19 and above, they would encourage you to use one of the adult evidence-based practices, something like cognitive processing therapy. EMDR would also be appropriate for adults. TFCBT has not been tested with people over the age of 18, so we can't call it an evidence-based practice because it's never been tested with. I mean, I suspect that it could work, but we really don't know, so we can't call it an EVP for adults.
Well, can I jump in and say, I have a client, senior in high school, they've just turned 18. Sort of developmentally, there aren't any significant differences other than the fact that they are 18. So I'm obviously going to continue providing her with TFCBT because she's still in high school, all of those things.
And the other caveat I would throw out there is I do think that in certain circumstances with, say, a 20-year-old who's operating developmentally at 14, 15, that it is appropriate. We're really more concerned about developmental age than we are chronological age.
Thanks. Great question. Other questions about sort of our clinician track? then that brings us to our supervisors. So our supervisors within the context of the Learning Collaborative are those that are more in terms of the clinical supervision rather than an administrative supervision role. So this might be individuals that might be providing oversight within their organization when someone comes to them and has a question or a concern about a TF-CBT case. Our clinical supervisors are going to be the people checking in, saying, hey, Matt, how many TF-CBT cases do you have? Like, how can I help you get more referrals so that we can make sure you're moving appropriately through the Learning Collaborative process? The clinical supervisors are also will be helping ensure that the clinicians are following the model with fidelity and also working with the senior leaders on how are we going to implement this within our organization, as well as sustainability with this. So our clinical supervisors get their own training, but they also attend all of the training for the clinicians. So that, there would likely, I would expect, usually people that are on the supervisor track also are on the clinician track, because that just makes the most sense. And many supervisors also choose to see their 3 cases and become rostered themselves as providers of TF-CBT. Right? So then expectations for all participants are that we expect that everyone is there for all learning sessions. Again, the learning sessions are going to be face-to-face. I didn't mention this earlier, but we are so grateful to be able to host them here at the Missouri Coalition for Community Behavioral Health. The mouthful. So all of the trainings will be here in Jefferson City. The food will be provided for the training. I mean, it's just incredible that we're able to do all of this. And then for those traveling from around the area, we are working to put together like a hotel room block as well to try to defer some of those costs. But hotel costs and travel costs that come to Jefferson City are costs that you would have to incur on your own within your own organization. So we do expect that everyone attends all of the learning sessions as well as participating in our conference calls. And so it's a little different how many conference calls there are for each of the training tracks. Sometimes people get really anxious over the conference calls. I had someone say, can I call in from Puerto Rico? And I was like, oh, bless your heart. No, you just need to be on the beach in Puerto Rico, right? So you can, for the clinicians, we can have you make up calls if you're going to be out of town or something like that. Just let us know. And Matt and Kate Drury, who run the calls, can work with you on those issues. And then again, that we are really, one of the pieces we're going to next talk about is that this is really a team approach, right? And so also committing to saying, like, yes, we are going to try to collaborate as this team within whatever you're defining as your community. And we've had a lot of that be distant before, where it's like phone conversations as people are spread over big geographic regions. So there's a lot of flexibility about what you're defining as your team. Okay, so the next few slides contain the information that's on page 9 and 10 in your packet. So we just put them in the PowerPoint to make you aware that these expectations are here. So I know some people have this information ahead of time. Are there any questions right now about the expectations for senior leaders or supervisors for any of the 4 training tracks? The training dates are in here. And I know actually someone mentioned the book earlier, so I'll jump in right now here with for the clinicians. So for each of the trainings, there is an online web training that we'll have you do. So that's the expectation is that happens before the first training session, which is at the end of March. You get free CEUs for doing that, which is pretty cool. And then we also ask our clinicians that you read the book, the TF-CBT book, which is not what it's called. It's Treating Trauma and
Traumatic Grief.
Yeah,
Children and Adolescents.
Okay, so it's Cohen, Manarino, and Dublinger, 2006. If you're accepted to the training, you're going to get a whole packet of information that has all of that, and
We'll be providing the book.
we'll be providing you with the book. So, which is also really phenomenal that we can do that with this training. Most of our trainings do have 5 books of stuff.
Can you repeat the name again? Just for the book.
Treating Trauma and Traumatic
I think it's Treating Trauma and Grief in Children and Adolescents, I believe. But I will say, if you Google those 3 names, Cohen, Manarino, and Dublinger, you'll basically find everything ever done with TF-CBT.
Okay, it's Treating Trauma and traumatic grief in children and adolescents. I believe it's $13.99 on Amazon, if anyone is like really excited to get started.
If you're really interested too, there's also a second book which talks about implementation of TFCBT in different settings, different populations like foster care, residential, I believe, with young children, things like that.
Just as a preview also of things to come, these trainings that we run are going to be very interactive and include things like prizes, one of which is the book that Matt is just referring to. So it's not going to be us lecturing to anybody all day for 8 hours a day, because that's not the best way for people to learn. So there are collaborative activities. Some of those will be done as a team. Some will be done in other groups. We'll have you practice skills and tools. So there's a lot of, for all of the training tracks, there's a lot of really concrete things to say, take this and go out and try this in your practice and let us know how it has been.
I have a couple of questions on the webinar. Anita was wondering, are you going to cover the parent-caregiver track?
We actually don't have a parent-caregiver track.
I didn't think so.
We have had foster parents before participate as a broker of service. So sort of on an individual level, we can talk through if that makes sense. I think one felt like it was really valuable, and another felt like it was kind of not the best use of his time.
Okay, and then Allison was wondering if you could quickly go over the training dates in March, October, and June.
Yeah, so the training dates, well, it's going to be a little bit different for each track. So in general, the first training session is going to be Wednesday. Sorry, my brain kind of figures out the easiest way to explain it. The 23rd through 25th of March. So what's important to note, that's a Wednesday, Thursday, Friday, and that Wednesday is just for supervisors and senior leaders. And then in May, it's the same thing. It's the 18th through the 20th of May. Again, with Wednesday being only for the supervisors, senior leaders. Same thing in September. It's going to be September 28th through 30th. And all of that is in your packet, because this is a lot of information. And then if you're accepted to the training, again, you'll get one packet that's like, this is what you need to do, so it's, all the information is in one place. Okay, yeah.
Just to clarify, those are in-person trainings,
Yeah.
right?
You got it, yep. Great question.
Okay, and then Thomas had a question. Are the expectations regarding the number of TFCBT sessions that are conducted or number of individuals that TFCBT is used with? Are there expectations?
Yeah, so for clinicians, if you want to be a rostered, our hope and like Emily's hope is that the clinicians will use TFCBT with as many people as possible, right? I was just looking at data from a different learning collaborative, and they're up to like over 200 kids have received TFCBT in an 8-month time period. Like, that's amazing in a region where there was only one provider a year ago. So we want you to use it with as many people as possible. In order to meet like the national standards, you have to complete at least one TFCBT case in the kind of 12-ish of the consultation period. If you want to be listed as a rostered provider of TFCBT, you'll need to complete 3 cases total, if that makes sense. So one totally completed.
I mean, basically, you have to complete 3 to be rostered or certified.
Yes.
One of them has to be during the consultation year.
So, for example, we had a learning collaborative that ended in December of 2014, and some people were kind of like halfway through cases. So let's say they finished cases in July of 2015, then they turn in their application to be rostered. That makes sense. So your 3 cases don't have to be done in this kind of 12 to 18 month time period. One of them does, yeah.
A couple more. If you already have a conflict with one of the training dates, can you not participate?
Yeah. Well, and it might depend on which track someone is doing, and ultimately, one thing we haven't talked about yet is that there is an application process and there is a selection committee, and so that might influence the selection committee's decision. Right.
Okay, and then how many clinicians can each site have involved?
That is a great question. So we have the capacity for about 100 people total over the course of over all of the different training tracks. Yeah, that we can accommodate. And so it will be up to the selection committee to sort of look at how many people are applying from what regions, how many people per team, and things like that. So I would encourage you to just go ahead and include everything you want as far as your team, and the selection committee might come back to you and say, actually, instead of like 5 clinicians back, we can accommodate 2 or 3.
Yep.
Okay. So then,
oh, hold on. Sorry, one more question. Can provisionally licensed LMSW PLPC participate?
yes, they can. Okay. All right, so moving on, we're going to spend some time now. This is just to orient you again, so hopefully this makes more sense. So now what we're going to be doing is talking about our next steps, about our learning collaborative teams, the team process, and what that's going to look like. So what we are asking is that everyone really takes time to think through what is my community that I serve, and who are the people that like have my back and are really committed to this mission of improving how we're responding to child trauma within that community. And so we want you to build on like your natural partnerships. I know there's some people here that are like, we went to grad school together and we collaborate a lot. Like, so that's a great opportunity to say this is a natural collaboration already, and how can we expand that to participate in the training. And so we generally recommend teams of about 6 to 8 people, but again, there's flexibility in that. Each community is going to be different, and so we don't want to prescribe it has to be just this number of people like that. And so in general, we found that it works best when there is a senior leader, a supervisor, clinicians, and brokers on the same team. Again, that's because we want, if I am a broker of service, like I need to know who can I refer to. Because prior to using this approach, we had trained children's division staff, and they're all excited about this, and then they don't know who they're going to refer to. And I don't know about you all, I feel a lot better referring to someone that I have met face-to-face, or like had extensive phone conversations with. Like, I just feel better that this family will be appropriately cared for if it's someone I know. And so that's what we really want to try to build on and foster, and help people that might be feeling really isolated. So the other thing you'll keep hearing me say is, if you're sitting here being like, I really want to do this, how do I put together a team? Contact us. We can help hook you up with other people, like through the collaborative process, to figure out who might be good people to help expand your network. All right, so now we have a little example to kind of walk you through and hopefully make this more concrete. Here, I'd like to introduce you to Selma, the therapist. Selma is super excited to be able to offer this in her community. So she thinks to herself, who are the people I collaborate with the most often? So then as she thinks about it, it takes a while, but she decides she's going to go with her senior leader, Shannon, who sort of is the director of her agency. So she approaches her, pitches this idea, gets Shannon really excited, gets the okay for like the supervisor, Sherry, to be involved, and then another counselor, Counselor Connie. And so then Selma, the therapist, thinks to herself, now, who else do I work with most often? So she realizes that there's kind of one caseworker and one deputy juvenile officer that she works with the most often. The person where if she has a question about like an investigation at Children's Division, she's going to pick up the phone and call that person. So she decides that Charlie, caseworker, is her guy who she's going to say, pick up the phone, call him and say, Charlie, we work together so often on cases. Would you like to join me and be part of this training? Same sort of thing with our DJ O'Danny, who also is going to help this process. Okay? So then everyone should have been emailed out. These next questions are part of the handout that we've included to people here. These are just questions for you to think through, because sometimes it is really hard. Everyone is really busy, and so it's hard to kind of think creatively about like, if I was putting together like my dream team of people responding to childhood trauma, who might that be? For some people that comes like immediately who they would call. For other people, it takes a little bit more work. We've also had people who have chosen to invite someone who's kind of the cog in the wheel, if you will, like the person that just really doesn't have the trauma lens and kind of holds back the team, or may very good intentionally do something that makes things harder for a kid. So you can also think through who are the people that are kind of already on board with this, or it may also make sense to think about, like these kids would be better served if this person would just jump on board and like stop restraining kids or whatever it is that might be going on. So again, we've just included these questions here because we found them to be helpful as you're thinking about who might be part of this process. Additionally, we want to really ask you to think through like where are there gaps in service provision. So we were just chatting with someone earlier today. For Matt and I, we often have families that live in St. Charles County, just outside of the border of the St. Louis region, and we have families that might move there pretty frequently. They kind of move across county lines, and then we just feel like it's like this, we don't have as many people to refer to there as we would like. So if it was me, I might reach out to people in that area and say, please come do this with us, because it would help me provide better service to the kids I work with, and it would help them. All right, so now let's walk through an example. Our caseworker, Charlie, has a child traumatized, Tammy, who is in a county where there just aren't enough providers of evidence-based treatment. Thankfully, traumatized Tammy gets to work with Counselor Connie, who is a fantastic therapist, is kind of a general provider of services. So then caseworker Charlie calls her up and says, hey Connie, guess what? There's this training in TFCBT that I think could be really helpful both for Tammy, who you're already seeing, as well as for other kids in your practice. Like, are you interested in doing the training with me? Connie gets all excited and she says, yeah, and you know what? We should also include Tammy's DJO Danny in this, because she's been getting in a lot of trouble because she has so many trauma symptoms, because the principal reminds her of the offender of her sexual abuse. She's not going to school and she's getting all these truancy referrals, because when she does go to school, she elevates, they have to restrain her and take her out. So again, they all agree to be part of the training as they move through the process. Connie is able to provide TFCBT to Tammy. Connie, the therapist, has difficulties with the family attending sessions, so she's able to work with Charlie, and they find out that it's like the family's work schedule. So the caseworker ends up bringing Tammy to treatment every other week, and then the family brings her the other 2 weeks, and so that eases the burden on the family, but we make sure that Tammy's still getting to treatment. Meanwhile, the therapist and the DJO are able to help work on how to reduce the triggers at school and how to help Tammy better manage those things so she's able to go to school. And guess what? Tammy gets better, right? She's actually had this treatment that we know is going to be effective for reducing her symptoms, and now she can kind of sort of move forward with this positive development that we would want for her. I'm sure you know what's coming, right? Guess what happens when they don't work as a team? Poor Counselor Connie, she's so worried about Tammy, but Tammy's not coming to sessions. She's got a long wait list. She doesn't have any choice but to close the case. So then Tammy's not getting any sort of therapy or treatment, which is only going to make the school problems worse. The school keeps calling the DJO. There keeps being these truancy referrals, and Tammy is sort of spinning out of control. So then we've got caseworker Charlie, who's thinking maybe I have to move her to a residential setting if she's not going to school and she's explosive at home, which we know is not ideally where we're going to want Tammy to be, right? And so we want to make sure that we do what we can to create these collaborative teams, because the research and our experience in practice really does show that it's going to be better for these kids that we serve. Right? It's kind of a little bit of a tongue-in-cheek example, but I saw a lot of heads nodding here. I'm not sure for those of you joining via the webinar how much that rings true, but it really is amazing the cases that I have worked on that have that collaborative interdisciplinary approach, how much easier it is for that child and that family to heal and to move forward. So with that in mind, everyone should have copies of their applications. And applications are due by February 15th. So there's a couple of different parts of the application that I wanted to walk through. So for each what you'll see is page 3 and 4 of the application. That's the team portion of it. So if Matt and I were on a team, we would fill out one of these for our team, and then our pages 5 through 8, you will have a page 5 through 8 for each person who's on your team. So if Matt and I are a team, we'd have 2 sets of page 5 through 8 and 1 set of those first pages. Okay. The online app, the electronic copy of the application is in a PDF form, so you can just type in answers if you prefer that. If you prefer to write it out, we've got the paper copy as well. Once you have the application, they'll be sent to Katie, because the selection committee from the Missouri Children's Trauma Network will be the ones making decisions about who will be accepted into the training. So Matt and myself, Missouri Academy of Child Trauma Studies, we have nothing to do with that process. So we are more than happy to help you figure out who makes the most sense to be on your team. Additionally, I love it when people call me and they say, here's what I'm thinking, which training track should I be on that makes the most sense. So for example, our last big collaborative in Illinois, I'd had a woman who registered as a senior leader, which made a lot of sense because she's finishing her MSW and wants to run a nonprofit. She wants to be a senior leader. But at this point, it didn't really make sense and would have been sort of a waste of her time for her to be in that role now, and instead made more sense for her to be the broker of service track to kind of get that broader systems perspective. Again, you can have people apply in more than one track. The only ones that you can't do two of, the clinician supervisor can't also do broker because they happen at the same time. So you can't be in 2 places.
So you're saying that a person can do a dual role?
Yes.
Yeah, you could be supervisor and clinician. You could be senior leader and supervisor, senior leader and clinician, truthfully, even too.
Yep, and our senior leaders get a really good gig in that they are welcome to come to any of the training tracks that they'd like. Yeah. Because we want them to have as many opportunities to understand what's the information that everyone's learning in these different sections. So senior leaders often kind of pop between training tracks. So yeah, so most of the learning sessions are Wednesday, Thursday, and that's where we'll have activities where we have all the tracks together, and then we have kind of breakouts. So we'll have the brokers of service and then the clinicians in different places. So that's why.
So clinician, broker, you couldn't do those two.
Exactly.
Or supervisor broker.
And the only other one that we've hit with other people before is that the only track that has educational requirements would be that, or the clinician track. So if someone is a supervisor, that doesn't have a master's degree, but they're not going to be providing TF-CBT, we can make that work. So other questions?
I know that some of them had asked kind of like the criteria of the selection process, and I actually missed the previous meeting on the committee, so if they decided those different factors, I wasn't there for that, but I'm sure that we'll have an outline of what those selection criteria are, but I don't have them with me. I wish Emily was still here. She'd probably be able to answer that better, so I apologize for that.
Yeah, the only one that I've heard consistently is really that they will be taking into account where are there existing providers of TF-CBT and trauma-focused services, and then where are the biggest gaps across the state. So I know that that is a factor. It's not the only factor.
Is there a way you can look that up and see that?
You can. So on the MOAC's website, there's a link to, there's a button that says roster, and there you can type in your, like, a zip code, and it'll tell you where providers are across the state. I would say there's a, just from, so if we jump in that, from where we've done a lot of trainings, there's a lot more in St. Louis and Kansas City than there are sort of in other parts of the state. However, I think we have 4 different collaboratives that are currently in process of TF-CBT providers that haven't gone far enough yet to be listed on that website that include people from other parts of the state. So.
I think the northern portion of the state is pretty underrepresented at this point. Around Springfield and Joplin, there are some that we train down like in the Cape Girardeau, Sykeston area, and we're doing some currently that kind of cover the middle corridor, Columbia, Moberly, Lake of the Ozarks, Jefferson City a little bit.
And what I will also say is that
county doesn't have.
Oh, probably not. Yeah.
Well, there's only 3 of us that work there.
Well, then no. If you're not one of them, no.
Well, so what I will also say is apply, right? The best way we can secure funding for additional trauma training is for Emily to go back to the legislature and say, hey, like, look at all these people that were at the launch event. Look at all these applications. We had way more people than we can accommodate. Let's do this again. And so don't let that sort of deter you. I think, one second, did you have another question? I cut you off. No, okay.
Can you apply on more than one team?
Oh.
My question is because I work with them in an administration role, but I also work in a totally different part of the state in a clinical supervisor role.
Yeah, we have had people before that have been parts of more than one team because it's what made the most sense for their role. I think
That
he
is
was also named that, but he was on 3 teams, so that was kind
probably going to be key for us because there are so few working counselors in a 10 or 12 county area.
Yep.
That.
So what I was thinking with that is we could pull people from the surrounding counties. Definitely.
Absolutely.
There's no,
Yeah, it doesn't matter how many clinicians that we have on that apply if they're part of our team.
exactly.
Okay.
I mean, we want this to be practical. Like, we want this to reflect what it is that you need, where are the gaps, and what is going to make your job easier and less miserable. And so, so we've had teams before where, they will do, like a phone consultation meeting, and talk that way. We have other teams, like at our organization where we sit down around a table once a week. And so it doesn't have to be, the people on your team don't all have to be sitting face-to-face together in order to be part of the team. The teams work a lot better when you as a team agree to like be an email communication or things like that because it just is easier.
And I would also just throw out the whole point of the team thing is really, it is specifically related to sustainability. What we know just from implementation science is that when you train one person in a vacuum in a model, they don't continue to do the model. But when you train a team of people and they continue to work together, that's when models get sustained. That's when they remain faithful to the model. You see better fidelity. So really, that's the purpose. It's not just extra work so you get to know people. It really does have a purpose related to implementing the model.
Sorry, were there more questions? Okay.
Where do you have learning collaboratives already in process in Missouri or that have already gone through the entire learning?
Okay. So our very first one was Washington, Missouri. Sorry that we're pointing, but
No, that's okay. And that one,
was a big geographic region.
yeah, that covered. Yeah, that was like there was some from St. Genevieve, St. Francis, Franklin, Washington, Jefferson. I think those.
We did that.
We've
done 6 in the St. Louis area. We did one that was it pulled people from around the state, and the training location changed. That was through the CAC. We did one sort of in the Boot Hill area of Missouri. Matt already mentioned the Mid-Missouri one, and then 2 in Kansas City. Then we've got a big group in Illinois.
And we did a 2-day training in Iowa.
Yeah. So I don't think that's quite covering all of them, but does that give you?
That helps me. Yes, thank you. And then, do any of those collaboratives have children's division team members on there?
Definitely.
That's who I need to hook up with and kind of pick their brains.
Yeah. So if you want to send me a note, or maybe we can follow up by phone, and I can help put you in contact. Great. Other questions? Oh, sorry. So for the application process, you can fax them to Katie, you can scan them in and email it, whatever is easiest and makes the most sense for you.
And the application has the fax number and my email on it. If not, we can resend out.
I have
all
her
the-
email, but I will add your fax number for when we post it.
When you call for authorization for Medicaid now, they ask if you're doing TFCBT. Does that mean that they're going to authorize 12 to 18 sessions because it's TFCBT?
That is a question that I actually have been trying to do research on this week because I think that this is it a recent change?
No, they started doing it like last year, but I asked, and of course
They've had this
because I was
question
concerned,
from multiple people.
will they limit your session?
Will they limit the session?
So if you're doing trauma focused and you're supposed to get it done within 12 to 25, then, or 12, yeah, but if you have it written down, then they're going to say, when you want to get another prior approval, well, you should be done with that.
Well,
I'm going to call and ask them that question.
Yeah, and I think that's also where that idea of TFCBT as part of a larger treatment process is an important one, because I don't think, I suspect that that would not mean you could only get 12 to 18 sessions.
I'm sure you can, write in and say it, but I was just wondering when they asked that.
I have not heard if they're going to be hardline about
I'm going to ask them. I'm calling offline now.
Fantastic. I will say that one of Emily's big goals that we're really working on is eventually, and I don't think it's there yet, to have a CPT code specifically for TFCBT or one for PCIT or other trauma-informed services, which is really great. And at least in the St. Louis area, they have created one for sort of the county level funding sources for trauma-focused services where there is a differential rate of reimbursement based on if you're using that versus if you aren't.
I have that wonderful stakeholder.
Oh.
It says, we have a question from Allison. It says, does TFCBT have to be done with a PTSD DX? CBT does.
Say the last part. I didn't hear the last
So what they're asking is TFCBT appropriate? Do you have to have a full diagnosis of PTSD? And the answer to that is no.
No. You do have to have what are believed to be trauma-related symptoms, but this does not have to meet criteria for PTSD.
And sort of related to that, the trauma needs to be, TFCBT doesn't work if it's a pre-verbal trauma. So there's other models that would be better for that.
Okay, Laura had a question. Which track would you recommend for in-home master level case managers?
I think probably the broker track is where we've included those people before. But that would be one too if we wanted to talk, what that means can look so different in different organizations. So if you do want to talk about it with us.
I think one of the biggest issues we've seen, if someone is going to be in the clinician track, you need to be certain that they can get clients. Because what we have seen a number of times is people go in the clinician track, but they're not regularly getting clients because they're maybe doing primarily intake.
Or psych evals.
And it's going to be a real mess. So you just need to make sure that they have a caseload that they can pull from.
So you can have more than one broker in the training, right? Yep. Okay, because you want to pull from the community, like your caseworkers, your JUB office, your CAC, and meeting. Okay, I like the way you're thinking. Okay.
Yeah, one way I think about brokers is kind of two things. Think about who are the people that are already referring trauma cases to you, and who do you want to refer trauma cases to?
Yeah.
Those would be, I think, a good way to think about it.
Okay. Because, again, the idea is we want to make it as easy as possible to help triage these families to where they need to be. And there's going to be kids where TFCBT isn't going to be appropriate. And so we also want to make sure that where it's not appropriate, we're getting these right. So a big piece of the broker track is we have an actual screener tool that includes a developmental trauma history and a decision tree so that if I am a broker of service, or if I'm family advocate at the CAC, I can like follow that decision tree to help figure out which child should I send to TFCBT versus PCIT versus general therapy versus psychiatry referral.
All the questions we have currently on the webinar.
Oh, I thought we would. Okay, so as more questions come up. Oh, yeah. Okay, so again, this just summarizes here that there's the team packet, the individual packet, and then the requirements page for each individual. CEUs, I haven't gotten that question yet, but we have CEUs for all training teams. And again, just to hit this point again, we want you to be as creative and flexible about who is in your team. So why is it worth your time to participate? We've included here, these are some feedback from training participants from other learning collaboratives. One that I had most recently was someone, when I sent them their note saying, congratulations, you're rostered, here's your certificate. They said that this has just profoundly changed their practice and how nice it is for them to feel like they're really able to more efficiently meet their clients' needs. That sort of pressure of feeling like I want to help but don't feel like I'm doing it as well as I can, that they just feel a lot more confident in these cases. And then this one, actually, the second quote came from a broker of service where they actually had a school-level trauma happen where there was a school emergency. A teacher was in her parking lot, and she was in her parking lot, and someone came and actually shot her, and they had all the students in the school. Like, this happened in the middle of the school day. And so this woman actually said, because I had gone through this training, there's core principles of responding, that she was able to help these students and help the school administrators figure out what do we need to do because there's this emergency happening and we want to shepherd the kids from this. And like, I sincerely hope no one ever has to be in the situation that this broker of service was in, but I was at least grateful if she had to be, that she felt more equipped and had all these tools for her. And then we just wanted to end with what students, kids, and families have to say about TFCBT. So this first quote here is from a 10-year-old girl who says, now I know that everything will be okay with my future. I'm not scared. That's a big deal for a kid to not feel scared anymore, to feel like that they have this positive future for them. Additionally, an 8-year-old boy, I learned that pushing away what happened will make it worse, that I can talk about what happened without it being scary anymore. Right? That memory has just become a memory. That emotion is no longer haunting that child. And then this next one is from a caregiver who says, so much has changed. She's engaged, expressive, and happy again. She not only uses her skills, but, wait for it, teaches it to her friends. I feel like we've got our daughter back, and I am forever grateful. Like, we didn't make these up. These were what were written down on sort of post-treatment forms with people. And, you know, each time I read these, I just think, I want this for all kids. Like, all kids in our state, in our, like, eventually country, should be able to have these same outcomes, and the people on the phone room are all people that can sort of help make that possible. And so with that in mind, we thank you for considering being part of the project and want you to approach us and Katie with any questions that you have. And we're just so excited. This is our favorite thing to do, I think. Well, I don't know. I love seeing clients too. But almost is my favorite thing to do. And we just can't wait to see what teams and collaboratives come up as part of it. So thank you very much.
Did I find out anything?
I did. Currently, it does not mean that you will get a extended number of sessions. However, it was put in the matrix, and as soon as the budget line is approved, if they are TFCBT and you are a rostered provider, you will get 18 sessions.
Right. So you get more sessions
Yeah,
authorized.
After the budget gets approved. So.
Okay. Before you start wrapping up, I'm going to turn it back over to Katie.
Yeah, I just wanted to kind of go through our website. It's new, so I just kind of wanted to go over it briefly so you guys kind of get an idea and you can go back to your agencies, look at it, share it. It is still a work in progress, especially on the research side. So if you guys, this is for you guys. So if you have resources that you'd like to share up there, or if you have things that you would like to see up there, please email me any of the documents or things you would like up there, and I can research and see what we can find to put up there. So this is just the home page, and then we have our story of kind of how it got started. And then this tab has all the different learning collaboratives we have going on currently. It doesn't have EMDR up there yet. That's something I'm still working on. So once we get that learning collaborative going, it'll be up here. But these are the 4 that we have currently rolling, which is motivational interviewing, the PCIT, which we're still working on a contract. It's a little bit more time-consuming working with a university. So we're still working on that one. And then we have the Trauma-Informed Learning Collaborative, which hopefully some of you have seen that email come through. It's a learning collaborative that's agency-focused. So it's helping you guys become a trauma-informed agency throughout. And we'll have a consultant that will be working on that within your agencies. They'll come in, kind of show you how to become more trauma-informed and go through that process. It is an application process as well, and it's out right now. So hopefully you guys will see that coming through. And then the TF-CBT training. So if you click on the drop-down, you can click on the motivational interviewing. It links directly to the registration, and it lists out the dates of the training and kind of a brief description of it. So you can see all those. It is regional training, and there is a 40 participant cap in each of those regions. So if you want to look into that, that is available. PCIT just gives you an overview of what PCIT is, so if you wanted to learn more about that, that's up there currently. And then the Trauma-Informed, which has the information about it. It's the 2-day training will be live, and then there'll be monthly ongoing TA with a consultant. And then there is a webinar next Friday that we'll be doing that kind of explains the Learning Collaborative. So if you're interested in there, you can go to the website and click on the webinar link to learn more about that if you're interested. And then the next one is the TF-CBT, and that will have, this is where you will go and have all the application. We'll post all that up here, and then the video of this webinar, because it has been recorded, so if you wanted to share it with anybody, that will be up there as well. And then the resources, which still work in progress. And then contact information, which will have my contact information and telephone, and I can actually put the fax number up there too, so if they don't see it on the application, it'll be there. So that's kind of a overview of the website. It looks like during going over the website, I had a couple questions. Due to turnover rates at facilities, will there be future trainings to add new team members if one leaves?
Oh, so that's a great question. The way the training is scheduled, a new person or team member could participate in like a different collaborative. So when we do this again, but it doesn't really make sense or work to change team members once you kind of get started.
I got a follow-up question. So like if you have another counselor comes in the area, do they have to do the application process to do that, or can they just sign up and come?
Oh, so they would have to, like once we get started, we can add people with the permission of the selection committee up until those March training dates. But once those March training dates hit, we can't add anybody else because they would miss that content, and there's no way to like make it up. So they would then they usually go on our list, and then we just let them know, hey, this is the next one that we're doing, and we scoop them up then.
And it might also be possible if there's not a learning collaborative, there are also opportunities to do sort of like a basic 2-day training here and there. So we will sometimes send out stuff for that as well.
Yeah.
So I think what the question there was like, if I die of a heart attack and Susie has another therapist in the area and she wants that person to take my place on the team, when they do the application process, do they just apply as part of her existing team?
Yeah, if it's before the If it's before the March date.
If it's after the March date, we would certainly want to try to find a way to get them trained. And so, I mean, that's just where we'd have to see if there's going to be another learning collaborative, if there's another training somewhere that we could get them.
And hopefully we will be able to secure additional funding for the next physical year so we can help progress the learning collaborative and not just drop it off and keep supporting it as we go. That's the whole goal of the trauma network. So we hope to be able to do that for you guys. I did have a couple more questions. Are the training hours approved by NDCC for renewal of national certification for counselors?
The training, it's issued by the Missouri Institute of Mental Health, so that would be a question I'd have to ask them. So I'm assuming the answer is yes, because we haven't had a problem with them being accepted before.
I'm going to stick my nose in there from the ACAM side. Yes, it would be for LPC, CEU's accounts, and for NDCC accounts.
All right, great, thank you.
Okay, and then one more question. Once we get started, if someone leaves, would the team still be allowed to continue? Like if you were in the middle of work and someone leaves, the team can still go?
Yes. Yep, definitely. The team's still able to move forward.
And then I had another question about cost, and we kind of briefly touched it earlier, but I'll go over it again. There is no cost for the training itself. The only cost for the agencies would be the travel to Jefferson City for those live trainings, so travel expenses plus the hotel stay for those attending. So far I haven't had another question.
Well, great. Well, thank you all so much for your time. And for those of you that happen to come to the live training, if you would look at your your agendas, and if your agenda has an asterisk on the bottom right corner, I think, then you will have won one of our door prizes. They're really fun door prizes. I won. Extra thank you for traveling to be here today.
I got more toys. You have to get it here online.
Come on, let's just go find one. Here, go get it.
The other one?
No, I won't.
All right, well then who do we think traveled the furthest to get here?
Texas County?
Yeah, that's
All right.
Where's Texas County? Where's Texas County?
Well, I was in Lebanon, and then Fayette, and then Butler, Missouri, and then Fayette, and then Columbia, and then Fayette, and then Jeff City. But that's over 3 days.
You got it.
She wanted the most.
You know what? You guys can open it up in spirit. No, I'm fine. I am fine.
All right, well, thank you all so much for being here. We'll be around if you have questions. Otherwise,
My son's in
call or
college.
text us. Have a great rest of your day.
Everybody on the phone call.
Where's Texas County?
Remember that the applications are due February 15th.
Okay,
Thank you.
An hour south of Raleigh.